I know that have been a long day, but we have this very last session that is extremely interesting since it's focused on the news on LM Main. So,
hello everyone, and we can welcome Dr. Satoru Mitomo for the first lecture today, Definition Criteria Bifurcation. Thank you.
Thank you so much. Thank you so much for giving me this wonderful opportunity to present to our study. I'm very honored to be here as one of the presenter for this wonderful session. Today, I'd like to talk about the real-world data of the PCI for definition bifurcation region. So first of all, let me share one case with you. 78 years old male presenting a stable angina. He had multiple coronary risk factors. Here now we have the hereditary bifurcation region, including the diffusely disease side branch with tight stenosis. So how would you treat this complex bifurcation region? Provisional strategy or systematic double stent strategy? The definition two trials showed that for definition bifurcation region, the systematic two-stent strategy was associated with significantly improved clinical outcome compared with the provisional stent strategy. Well, what is the complex bifurcation region? The definition criteria consists of two components, major criteria and minor criteria. If a region had one major criteria and at least two minor criteria, at that time we can say that the region is complex bifurcation region. So this time we conducted New Tokyo definitional study, which was retrospective observational study. We reviewed all the PCI cases performed in our center from January 2015 to December 2021, from 10,712 cases. After excluding these cases, finally we got 574 cases which met definition criteria, and then compared the provisional versus systematic double stent strategy. This table showed the baseline characteristics. Their comorbidity and medical history were well balanced between the two groups. Regarding clinical presentation, around 80% of cases with stable angina in both groups. This table shows region characteristics. More than 60% of the region were made in the 111, and ADD bifurcation were mostly included in both groups, but distribution of the region were different between the two groups. Moderate to severe calcification was found in around 1/4 of the cases in both groups. Regarding the procedure characteristics, it should be noted that intravascular imaging guidance was performed for more than 90% of both groups. And regarding the stent techniques, mini-crush was mostly taken for the systematic double stent group. On the other hand, TAP was mostly performed in the provisional stent as a variant stenting. Both with high pressure non-compliant balloon was performed at high percentage of the cases in both groups. And then clinical outcomes at 3-year follow-up, clinical follow-up, there was no statistically significant difference in TLR rate between the two groups, 6.3% versus 5.8%. Regarding the TVR rate at 3-year follow-up, again, there was no statistical difference between the two groups. In our study, there was only one diagnosed of MI case in the systematic double stent strategy and no cardiac deaths in both groups. After that, in order to adjust their background, we conducted a propensity score matching using these variables, and then we got 151 pairs. Even after propensity matching, a TR rate at 3-year follow-up was comparable between the two groups. At this point, let's see underlying differences between the two studies. The original study was a randomized controlled trial, but on the other hand, a study was retrospective observational study. In the original study, PCI procedure was predefined, so the regression decay crash and curate was strongly recommended for the systematic two-stent study groups. And also, there are some differences in the clinical and angiographic protocol between the two studies. If we look at the clinical outcomes, our New Tokyo definition study was longer follow-up period, comparable clinical outcomes between the two groups, and less incidence in both groups. How about the differences in the PCI techniques? As I already mentioned, the stent techniques were completely different between the two studies. Intravascular imaging guidance was performed at extremely higher percentage in our study, and both was equivalently performed in both studies. In order to partially explain why there was differences in the clinical outcome between the two groups based on the differences in their technical aspect, let me show you two representative cases from our study. This is a case of a ready to bifurcation region which was treated with the cross technique. For this region, we put the two stents like this, and this is final angiography. And then 18 months after the index procedure, we performed coronary angiography for recurrent angina. We showed that significant restenosis at ostial diagonal ostium. Then if we look at the magnification, we can clearly appreciate the gap of the stent between the main branch and side branch, which was also confirmed with IVA separation. So we had a geographic miss resulting in a significant TOR at the ostium of diagonal. And this is another case of the ready true bifurcation region, which was treated decay crash technique. For this region, we put these two stents with a decay crash technique, and this is a final angiography, looks pretty good. And then 24 months after the next procedure, we performed follow-up angiography, which showed still excellent result. And then if we look at the magnification, for sure, the side branch ostium region was completely covered with side branch stent, which was also confirmed with IVA separation. Actually, in our study, we had 8 TORA cases in the systematic double stent strategy, and 6 of them were associated with this kind of geographic miss. So actually, this is just a hypothesis, but if we treated this region with decay crash, at least we can avoid this kind of geographic miss, and maybe there might be the possibility to have a better clinical outcome in this systematic double stent strategy, but this is just hypothesis. So in our large cohort of real-world definition bifurcation region, we had comparable free clinical outcome between the provisional versus systematic double stent group. High percentage of intravascular imaging guidance might contribute less incidence in both groups, even at 3-year follow-up. As systematic double stenting, decay crash might have advantage to overcome variation of complex bifurcation morphologies, including a bifurcation angle, a cell size discrepancy, or a certain plaque distribution around the side branch ostium. Thank you so much for your kind attention.
Questions?
From my part, congratulations, because that's a good clinical practice example. That's my opinion.
Some explanation, Dr. Sheiban. Some explanation about the difference between results in trials and in registries.
Difference are based on retrospective study.
Yep.
And randomized study for one side. The second is, as he underlined, that in decay crash, in definition, decay crash was systematically used in one study. In the other study, you have different approaches, which more probability of bias in technique. Mm-hmm. So I think this is the fundamentally what is the difference, why this difference between results.
Yes, I agree with you.
And do you think that the mini crash could have played a role, because that was the favorite technique in your study as compared to the definition, right? And for instance, I correct me if I'm wrong, but I think I remember that in the October trial, for instance, mini crash was discouraged because you cannot be sure that you can oppose the carina, the stents, and guarantee perfect scaffolding. Do you think that this could be also a factor influencing the discrepancy between the trials or the studies?
Yeah, so basically, in my opinion, especially for Japanese people, we thought that if we have to micro-rated stents rot, it should be worse. I mean, it can result in worse clinical outcome, causing restenosis and stent thrombosis. That's the reason why previously we performed much more mini crash technique. But as I showed you, sometimes if we have the shallow angle, it can result in geographic miss. Also, it can lead to high restenosis and even the stent thrombosis. So now, after reviewing these data, and we have a lot of data, especially including the bench test. Now, I'm more comfortable to perform DK crash than mini crash.
Okay.
You did a lot of imaging, and maybe you said it, the results are good because of that. Did you have many changes of your decision on how to treat regarding the imaging? Because on the first case that you showed, you didn't do the imaging, and you can see that there was a little bit shadowing on the ostium of the diagonal. So maybe because you did all those images, it changed your decision to how to treat. Not just the definition criteria.
Mm-hmm. Yeah, so actually, if we are talking about the indication of the PCI for the side branch, especially side branch, we have a lot of the methodology, for example, physiology and the intravascular imaging. But at that moment, we didn't perform the physiological assessment to evaluate the ischemia in the side branch, but according to the significance of the region, we decided to treat the side branch with the two-stent strategy. But after that, we honestly appreciated that we had a geographic miss, even at the index procedure. But what we could do for that situation was just from the addition. We wanted to avoid to put another stent or just to cover the geographic miss. So especially for that case, the choice was very limited.
What about lesion length in both groups? Was similar on side branch? Side branch lesion length.
You mean systematic double stent strategy and the provisional?
Yes.
Yeah, almost the same. I didn't show you.
No significant difference.
No.
So that could be another point. I mean, that could be another point in the difference in outcome, because I think one of the major factors influencing the outcome is the length of side branch of lesion on side branch, and I think that should be considered in your study.
Yeah. Thank you so much.
Thank you. So
you so
we
much.
move forward. Next speaker is Majd Protty, Temporal Trends in In-Hospital Outcomes Following Unprotected Left Main PCI, Analysis of 4,522 cases from BCIS database.
Thank you. I'd like to thank the organizers for inviting me here today to talk to you. The title of my presentation is The Temporal Trends of In-Hospital Outcomes Following Unprotected Left Main Stem PCI in the UK. This is an analysis of the BCIS database, including about 14,500 left main PCI cases. My name is Majd Protty. I'm one of the PCI fellows in South Wales in Cardiff. So the work that I'll be presenting to you today has been published earlier this year in Circ Intervention, and I would urge you to look at this paper because it'll have a lot more data than what I'll be able to present to you today because of the time limitation. It was a national collaboration spearheaded by Tim Kinned. So to give you a bit of a setup, so the aim of the study was to examine the annual volume of left main stem PCI done in the UK, and to look at the change in the in-hospital outcomes over the study period from 2009 to 2017. And to do that, we used the BCIS database, which is the British Cardiovascular Interventional Society database of all PCI carried out in England and Wales. We excluded emergency presentations from the cases that we identified in this database, and that included STEMI and cardiogenic shock. So none of the cases that were analyzed had any immediate clinical need for revascularization. And we identified and studied, therefore, the final number was 14,522 left main PCI procedures. We looked at the baseline procedural and outcome variables. We looked at them unadjusted, and then we adjusted for them with multivariate modeling. So to look at the crude numbers, first of all, during the study period, the panel on the left-hand side here, from 2009 to 2017, there's been a rise in total number of PCI from 60,000 to 75,000. And that was mirrored by a rise in the number of left main PCI done during the study period to more than doubling from 1,000 to 2,600. Now, on the right-hand side panel, when you look at the proportion of PCI that was done for left main, that also rose from 1.8% of total PCI to 3.4% of total PCI during the study period. But it wasn't just the numbers that increased. It was also the complexity of the patient and the procedure. So during the study period, there was older patients, 70 versus 71. There was more diabetic patients, 22 versus 28%, more valvular heart disease, more patients who've had a previous PCI, and more number of vessels diseased as well as attempted in the cases. And in terms of the procedure, there was more uptake of intracoronary imaging during the study period, so it rose from 40 to 58%, and I think yesterday we saw more contemporary data showing the rise of intracoronary imaging in left main in the UK to more than 70%. More use of rotational atherectomy and cutting balloons as well as microcatheter use. So there's an increase in the complexity both on the patient level as well as the procedure level. Now, if we look at the crude outcomes, first of all, the panel on the right-hand side, if you look at the risk of any procedural complication, then that's been declining during the study period, down from 9% to 5%. When you look at some examples of complications, you've got less coronary dissection, less slow flow, but there's no difference in shock induction or side branch loss during the study period. Now, these are crude data, so let's come to the adjusted data. Now, we were interested in the trends year on year, so we adjusted for all covariates and compared them to the reference year of 2009. And again, when you look at the risk of in-hospital MACE on the right-hand side corner, then there's a year-on-year decrease in in-hospital MACE. That was not driven by in-hospital death, but it was driven by in-hospital per-procedural MI. When you look at the risk of any procedural complication, that again had been coming down after adjustment, but there's no risk in in-hospital major bleeding, no difference over the years. And the last thing that we did was to look at which covariates could independently predict poor outcomes, in-hospital outcomes, following left main PCI. So anything to the right-hand side of this line of no difference is associated with adverse outcomes. Anything to the left-hand side is associated with better in-hospital MACE rates. And you will see, for example, age is associated with worse outcomes. So for every year older, there's an additional 2% risk of in-hospital MACE. Female sex was also associated with worse outcomes. And baseline comorbidities, specifically peripheral vascular disease, chronic kidney disease, and ejection fraction less than 30% were also associated with worse outcomes. There are some procedural elements as well that were associated with worse outcome, for example, using a dedicated bifurcation two-stent strategy, 2B3A inhibitors, or mechanical circulatory supports. In terms of the variables that were associated with better outcome, and we've shown this before in this data set, an older version of this data set, intracoronary imaging. The slides were shown by previous presenters. That led to better in-hospital MACE. And the year of PCI, we saw that in the latter years, as I showed you earlier, year on year, there's been an improvement in the outcomes. So more contemporary data is showing better outcomes in left main PCI in the UK. So we discussed why that is in the paper, but basically to conclude, we have seen increasing number and complexity of unprotected left main PCI in the UK over time. And there's a significant trend for lower in-hospital MACE and complication over the study period from 2009 to 2017, which is the data that we managed to get our hands on. In our discussion, we try to see why that is, because remember, this is retrospective data, so we don't have the fine granular details as to why that is. But we believe it probably reflects improved technologies, techniques, as well as greater operator experience. But ultimately, this data is important to inform procedural planning, to guide the patient in terms of their choice and consenting to the procedure, as well as involving the heart team discussions and empowering them. Thank you very much, and I'll be happy to take any questions.
Questions?
Excellent demonstration, thank you. There's one thing that I wasn't very attentive at your presentation. Why did you exclude the acute coronary syndromes in your?
We didn't exclude acute coronary syndrome, we just excluded STEMIs.
Okay.
The idea is that if a patient comes in at 3 a.m. with a STEMI involving the left main.
I mean, these are the procedures that PCI is doing its best. So maybe it's a fair comparison to include those one also.
Well, most clinical trials will exclude a STEMI as well from left main particularly, and we know that they have poor outcomes in general as a population. So we didn't want the data to be skewed in that direction. Same for cardiogenic shock. And also, I've worked in centers where there are operators who don't do left main PCI, but they will admit that if a patient comes in the middle of the night with cardiogenic shock and it's 3 a.m. and they are the only operator on site, they will crack on and do it despite their lack of experience in left main PCI.
So congratulations. I think it's a great result because as we see, the complexity of the patients is increasing. They are older and more risk factors and so on. I would like to ask you which parameters did you choose to adjust your multivariable analysis? Did you include all these differences in clinical parameters?
Yes, we included all the parameters that were available to us in the database, and we've done this in other papers from the same database. That seems to be a reflective adjustment and hasn't over-adjusted in our experience. So all of the variables that you've seen on one of the graphs were adjusted for.
So it's great results to improve the MACE with this worse profile of the patients. Yeah.
Absolutely.
Congratulations for the excellent analysis of such a large database. I'd like maybe to comment on some findings that probably are just a marker or more severe disease, like the intra-aortic balloon pump or the use of circulatory support, Pella, or the two-stent techniques, and so on. I guess during the study period, this circulatory support, the so-called protected PCI, which is currently a common trend nowadays in unprotected left main, was probably at that time anecdotal.
Yes.
And I guess that, I don't know, probably you don't have this information, but probably has risen.
It has been rising. It is in the paper that we had there, but you're absolutely right. So one of the variables that predicted worse MACE is the use of 3 or more stents. Now, we don't think that's because you're putting 2 short stents together. It probably reflects the lesion length, the complexity of the disease, which is not something that we can measure. So, for example, in this database, we don't have the Medina classification of the disease. We don't have the amount of calcium in this, but we could use other surrogate markers, as you said, for example, 3 stents or more, dedicated 2-stent strategy up front, mechanical circulatory support as a reflection of the complexity. And sure enough, we've published that before in a different data set, all-comer PCI, showing that these predict complex high-risk indicated patients, the CHIP cohort, including mechanical circulatory support.
Have you tried to see if there are any difference between in outcome among different syntax scores?
We don't have the syntax score data on this database, unfortunately, which is always something that the reviewers come back with. The reviewers always come back with, what's the Medina's classification of all these 14,000 cases, and what's the syntax score? And this data is not recorded routinely in the BSIS data set. But that would be another interesting finding.
Sure.
And
You
always
showed that down here.
Oh, yes, I see.
You showed that the risk decreases by year. Now, what do you think the year is a proxy of? Is that increased operator experience, and how much is it exactly?
How much is the operator experience? Or
No. The improvement by year.
Yeah, so I showed that earlier. So everything was compared to the reference year of 2009. And since then, there's been a year-on-year improvement.
How much is it per year?
I'll show you the slide if you can give me the slides back.
And my question is, do you think, I mean, year doesn't really tell us anything.
No.
but it must be a proxy for something. And could
Absolutely.
it be proxy for increased experience?
So increased experience is definitely something that we suggest in the discussion. So we saw that there was 1,000 left main PCI in 2009, and that rose to 2,600. So I don't think there's been many new consultant appointments during that time. So it must be the same people who were doing it in 2009 that had gathered greater experience. And we've previously shown a volume relationship version with that. You commented about operator volume, I think, earlier. And we've seen that for left main PCI. So that's one of the things that we think could have influenced this. The other thing is newer technologies or better understanding of bifurcation techniques, angled microcatheters to access side branches that might be more difficult to access. I think all of these things are probably contributing to it. But if I have to pin it down on one or the other, it's difficult without all the granularity of the data.
Any data about the concomitant other coronary artery disease and eventually also the revascularization, the adequacy of complete revascularization?
So we do have data on the lesions and the disease pre, and that was adjusted for as well. The adequacy of the revascularization is not something that's recorded. Like extent expansion, for example, or the MLA or the MSA, it's not something that's recorded, unfortunately. But this is real life practice, and it just shows what we've been doing over the years.
Okay, thank you very much. We're going for next presentation. Clinical outcome of PCI on left main trifurcation stenosis. Mila Kovacevic, please.
Thank you. But this is broken, I think, this one. Dear Chairman, dear ladies and gentlemen, it is my pleasure to be here and to present some overview about left main trifurcation lesions and clinical outcomes. Let me see just, okay. We all know that left main trifurcation has some specificities. For example, like there are two side branches, at least 4 angles. We cannot say this bifurcation, it's trifurcation angles. And also the Finnett's law is different. Regarding the left main trifurcation classification, we all know that there are several classifications. First one, and very well known, Medina classification. There are also Shamas classification and ABCD. Of course, we are well known, we are much familiar with Medina classification. What is known so far about left main trifurcation lesions and outcomes in these patients? All the data comes from the small observational trials, and you can see, just maybe, okay. All the data come from small observational trials, with the largest one being MITO registry or Milan New Tokyo registry with the 84 patients. And regarding the MACE, you can see and you can appreciate that there is like variability between 9% in Tamburino and 34% at Shamas study. However, there was different definition of MACE in Tamburina, for example, registry. They didn't include target lesion revascularization compared to other studies. What can we say about the impact and outcomes on left main trifurcation lesions? First, we have to speak about impact of anatomic complexity, then impact of stenting strategy, and what do we know about left main trifurcation versus left main bifurcation lesions. Regarding the impact of anatomic complexity, as you can see, the true left main trifurcation lesion was present in about 40 to 70% of patients. In some studies, they're not reported. They didn't report the number of true left main trifurcation lesions. When we go back again to MITO, the largest one registered so far, you can see that patient who had true left main trifurcation lesion, they had worse outcome, particularly MACE, and of course target lesion revascularization rate. Regarding the stenting strategy, of course, one stent technique was applied in about 15 to 60% of patients, and you can see that the 60% of patients received 2-stent technique in Kubo registry. In Gil, I'm not sure I will pronounce correctly, they also applied a dedicated bifurcation stent. What can we say about impact of stenting strategy? It didn't influence the maze, as you can see in Mito registry on the left. However, it did influence the target lesion revascularization rate, particularly number of instant restenosis, and the majority of instant restenosis was at the ostium of the left circumflex. Regarding the Kubo registry, they included 72 patients, and they performed systematically tracing. Either it is one stent technique or 2 or 3 stent technique, and what they concluded that multi-stent technique was influenced a high rate of target lesion revascularization rate compared to patient where they apply single stent technique. And again, they performed systematically tracing in all or triple balloon kissing in all patients. Regarding left main trifurcation versus left main bifurcation lesion, we just have extrapolated data from Excel trial. They included 61 patients with left main trifurcation lesions, and as you can see, there was no difference between trifurcation and bifurcation lesions, with even less numerically maze in patients with trifurcation lesions. Do we have new data? We decided to do another multicentric retrospective analysis. We included 103 patients with left main trifurcation lesions, all comers, STEMI, non-STEMI cardiogenic shock, in 4 tertiary high-volume centers, 2 centers from Italy, Gemelli Hospital in Rome and San Raffaele Hospital in Milan, and the 2 centers in Serbia, Clinical Center of Serbia and my hospital. The primary endpoint was maze, a composite of all-cause mortality, MI, and target lesion revascularization. The secondary endpoint was target lesion revascularization. So when we compare to other trials, our trial, the follow-up was 3 years. We included true left main trifurcation was present in 24% of patients. We mainly performed provisional single stent technique in 76% of patients. Tracing was applied in 15% of patients, and geographic success was achieved in 97% of patients. And regarding the maze was present in 17.9% of patients, particularly due to the target lesion revascularization rate, which was 11.9%. Regarding cardiac death, it was present in 3.9 patients, and overall cause mortality in 5.9% of patients. What we particularly wanted to do to examine how angiographic left main trifurcation complexity influenced the maze. So first of all, we created another score. It was a great idea of Francesco to do sum of Medina points. For example, in this particular case, this is sum of 3 Medina points. Then to add 1 point for side branch lesion length more than 5 millimeters, we decided to use a cutoff of 5 millimeters instead of 10 millimeters in definition trial, thinking that maybe 5 millimeters in 2 side branches would be comparable to 10 millimeters in bifurcation lesions. So 1 point for side branch length more than 5 millimeters, as in this example only circumflex has side branch length of more than 5 millimeters. So in this way we created modified Medina trifurcation score with a maximum or total of 6 points. Then we did perform univariate analysis for all anatomic, clinical, procedural factors. And as you can see, these variables are independent predictors of 3-year maze. However, when we performed, I don't know why that's, multivariate analysis, only modified Medina trifurcation score, this was the only independent predictor of 3-year maze. Regarding the secondary endpoint, TLR, 3-year TLR, number of deaths in left main trifurcation was the only independent predictor of 3-year target lesion revascularization. So what we can conclude, that PCI in patients with left main trifurcation lesion is technically demanding, might require dedicated techniques, might require 2 stents, 3 stents, 2-step kissing or tracing technique, but may result in high rates of angiographic and procedural success. And also it is associated with acceptable MACE rate of 17.9% in our trial that can be independently predicted by our modified Medina trifurcation score. Thank you. This is broken. I didn't break it. I don't know how, but it.
I have a question. In how many percentage did you use imaging, and was it reserved only for the true bifurcation with your modified Medina score? And also about tracing, did you did it systematically, or and in provisional stenting, did you do it all the time or not?
No. Regarding the imaging technique, it was applied in 35, I think, % of patients, with majority of them performed the OCT, 20% OCT, and 15% of them we performed the IVUS. And regarding the tracing, tracing was, as I already showed, that it was applied in 16% of patients. But 2-step kissing, it was applied in majority of patients, 60% of patients. And POT, for example, it was done in 90% of patients.
Congratulations, extremely stimulating and also extremely clever, the modified score. But we find now in the trifurcation between Sheila and Caridi, meaning on one side you showed us in a convincing way that multiple stents are related to adverse outcomes. On the other way, we know that in trifurcation we have a mismatch between the usual strategies that's left main to the LAD stenting, because it's usual, not always, but it's usual with a very large difference in diameter. So give us your recipe.
Yes, of course. There is, on the first slide, I already showed like the Finnett's law regarding the left main trifurcation lesion. Yes, there can be a very mismatch between the size of the left main and, for example, other side branches, LAD or ramus or circumflex. However, if there is, we are speaking about true left main trifurcation lesion, then we have to appreciate that the side branch diameter should be more than 2.5 millimeters. And regarding all the stenting platforms now new available, that we can stretch them from 3.5 to 6. So nowadays it's not difficult to treat left main trifurcation lesion with the available 2nd generation or 3rd generation of DES. Especially in our trial, compared to other observational analysis, we treat all the patients with 2nd generation DES and drug-eluting stent, compared to previous when there was also the 1st generation of drug-eluting stents. And so
but yours has to be always supporting provisional stenting.
Yes, in a situation when there is possibility to treat it with provisional single stent, maybe this is the better choice. However, we already saw the definition 2 study and the criteria for the complex lesion, not the true left main trifurcation or true left main bifurcation, but the complex bifurcation. And as the colleague already showed, when we have for bifurcation lesion more than 10%, 10 millimeters in length and more than 90% of the side branch, then maybe it could be the patient that should be treated like with the 2-stent technique in advance. However, in our cohort of patients, minority of them was treated, not minority, but one quarter of patients was treated with the 2 or 3 stent techniques.
I just provisional technique, which was mostly used, which 2 stents or 3 stents technique, bifurcation or trifurcation technique, was predominantly in your study?
It was TAP, TN protrusion technique, yes, in majority of patients.
Mila, congratulations for a very nice study. How many patients actually received 3 stents at the trifurcation, and how did they do on follow-up?
in our trial, I think it was like 5% or 3%. It's a very small number of patients that deserve the three-stent technique. Very small number of patients in this particular trial. Probably probably because it's observational trial registry, that all the patients who had probably higher syntax score, like maybe scheduled for surgery. So maybe this was the reason that we utilize mainly one stent technique than two stent techniques. Although, for example, in our analysis, 1/3 of patients had a syntax score less than 22. 1/3 than 22, 32, and also third of patients had syntax score higher than 32.
Yeah, I have seen the score was based on the lesion length on
Yes.
side branch.
Yes.
What about calcification, which is very important in these cases, and it's very often is very calcified lesion?
Yes, yes. Thank you for your comment. We didn't estimate the presence of calcification, just the lesion length in ramus and left circumflex.
And why 5 millimeters, not 10 millimeters?
Yes, that's something that I explained. We thought that maybe 5 millimeters in two side branches could be comparable with 10 millimeters in one side branch when we speak about left main bifurcation lesions. But
Okay,
good point for sure.
Okay, I think we can move forward. Thank you, Mila.
Thank you.
So, next talk by Sandeep Arunothayaraj. It will be on the EBC Main trial 3-year results, randomized comparison of stepwise provision. We know what is EBC Main. No.
Great, good. Thank you. Thank you very much for the invitation. And I'd like to present the 3-year trial updates from EBC Main. And obviously this was a trial, a randomized comparison of stepwise provisional versus a systematic dual stenting strategy in the left main bifurcation. Presenting this information on behalf of the EBC Main investigators, of whom there are many in the room at the moment. Just like to acknowledge Medtronic Europe for funding the study. Now, we know that PCI for left main disease, and this has been from multiple randomized controlled trials, for disease that is low to intermediate syntax score that involves the left main, has comparable 5-year survival to coronary artery bypass grafting. PCI obviously has the benefits of less procedural risk and less time to discharge. However, longer-term results are still superior for coronary artery surgery. So it's really important for us to optimize our PCI procedure to try to chase a surgical-like long-term result. There's been a lot of debate regarding what the best bifurcation technique to use in the left main should be. And to date, randomized studies that have involved a large number of people with long-term follow-up have all investigated DK crush, and that's specifically been in an Asian population with high complexity disease. Now, in that setting, DK crush has performed very well and has shown superiority to both the provisional strategy and the Clot strategy for important endpoints of myocardial infarction as well as TLR. EBC Main was designed to compare the difference or similarities between a provisional strategy to an upfront dual stent strategy in a European population with true left main disease with low to intermediate syntax scores. Kissing balloon inflation was routine for both the strategies in this population, and a modern drug-eluting stent platform was used. In all, 467 patients were enrolled from 11 European countries, and the trial was run by CIRC. Now, patients recruited for this study averaged about 70 years of age. They had a high incidence of previous PCI, and over a third presented with an ACS lesion. The mean syntax score was right on the borderline between low and intermediate. A fair amount had bystander PCI, almost half, and intravascular imaging was used to guide about 40% of the cases. You can see that overall the side branch lesion length averaged 7 millimeters, but importantly there was a difference between the two groups despite randomization, and the dual stent group ended up having longer disease lengths, with 25% having a side branch lesion length of 10 millimeters or greater, compared to only 9% in the provisional. You can also see the side branch diameters on average was 2.9 millimeters. Now this was by QCA, which tends to underestimate the luminal area. And actually, if we look at this side branch stent platform inserted, the median was 3.5 millimeters. In terms of the two-stent strategy used, the most common was Calotte, and this was followed by T and tap techniques. The rate of crush stenting was quite low in this study. You can see the rates of pot and kissing balloon inflation there, and they were high for both strategies. Now, the 12-month outcomes were reported back in 2021, and at this stage, MACE was not significantly different between provisional or dual stent cohorts. What was noteworthy was that only 1 in 5 patients in the provisional cohort ended up with a side vessel stent, and these patients obviously overall contributed to a group that had shorter procedures with less radiation and less cost, much like we saw in EBC2. We now have 3-year follow-up results, which has been completed in 463 of the 467 patients. The primary endpoint definition remains the same, which is a combination of all-cause mortality, all myocardial infarction, and target lesion revasc. We also looked at bifurcation-specific events, and we made a composite endpoint of procedural or sudden cardiac death, target bifurcation-related MI, or target bifurcation revascularization. Now, these were the outcomes of MACE at 3 years. This was presented by David Hildig-Smith at UK PCI earlier this year. We could see that actually there was still no significant difference in MACE at the end of 3 years, but there was a clear trend in favor of provisional strategy with rates of 23.5% versus 29.5%. Now, when we looked at the individual components of the primary endpoint, we could see that mortality and myocardial infarction remained largely similar between these two groups. However, if you come down to target lesion revascularization, the provisional strategy had almost half the rate of the systematic dual stent approach at 8.3% versus 15.6%. And also, if we look at specifically bifurcation-related MACE, this was 15.2% versus 22.4%. So both of these were quite much in favor of a provisional strategy. Now, this forest plot depicts subgroup interactions for the main MACE outcome. And interestingly, significant interactions were seen for side vessel caliber as well as side vessel lesion length. And we'll go into this in a bit more detail in the next few slides, but all of this is now subgroup analysis and should really be considered hypothesis generating only. So this slide shows curves which explore the effect of side vessel caliber on the primary outcome, stratified by the strategy the patients were assigned to. You can see the Kaplan-Meier curve on the left, which looks at provisional strategy, and really the MACE outcomes did not seem to vary based on side vessel diameter. However, if you look at the dual stent group, patients that had smaller side vessels really did significantly worse in terms of MACE outcomes. And when we looked at the stent platforms used, patients that had 3.5 stents or smaller did worse in MACE compared to patients with 4.0 platforms or larger. Now, this is in line with previous data that shows that stent failure is at a lower risk if you use larger stent platforms and achieve greater stent expansion. And I think this may be particularly important in the left main, as when you come across your side vessel ostium, which is often your circ ostium, there are mechanical reasons where you may not get full stent expansion at this site. If we swap onto the effect of side vessel disease length, instead of affecting the dual stent strategy, this seemed to really affect results with the provisional strategy. And you can see here that side vessel disease length extending 10 millimeters or beyond is associated with increased MACE with time, whereas it didn't seem to affect the dual stent strategy that much. Now, this is important because it may indicate that kissing balloon inflation by itself in the setting of extensive side vessel disease may not be sufficient. Even if you have a good angiographic result, you may need to do a stent for this, or potentially this might be an area where drug-coated balloons show some promise. So putting these results together, it is apparent that the provisional strategy for EBC Main tended to show better outcomes when side vessels were smaller and when side vessel lesion lengths were more limited. The majority of patients recruited into EBC Main fit these anatomical characteristics, and this really influenced the overall outcome of this trial. Now, the question everyone will ask is, well, how do the results of EBC Main fit in with what we already know about left main bifurcations? And most of the data in this field comes from DK Crush 5. And it would seem that both of these trials are very oppositional. The EBC Main favors provisional, DK Crush favors a dual stent. How do we reconcile this? So I think some of the information we have from our sub-analysis of the EBC Main data helps with this, because we know now that anatomical factors have a strong influence in the outcome of bifurcation techniques. And when we look at the populations in EBC Main and DK Crush 5, they really couldn't be more different in this regard. Looking at the syntax scores, so 44% of DK Crush 5 patients had a syntax score of greater than 32. If you look at definition complexity, this was in 32% of DK Crush 5 patients and in 1.5% of EBC Main. Provisional side vessel stenting was required in almost half of the provisional patients in DK Crush 5, and the side vessel lesion length is over twice of what was found in EBC Main. And with the limited data we have in EBC Main, looking at patients with these type of factors, there was a trend that dual stents may be better. So I would suggest that essentially the trials that we have, DK Crush and EBC Main, are actually complementary. And what they do is they compare two different bifurcation techniques applied at two different ends of the spectrum of disease complexity. So in summary, the conclusion after 3 years of follow-up was that the majority of true left main disease that we encounter in a European practice is best treated through a provisional strategy with routine kissing balloon inflation rather than an upfront two-stent approach. Now this led to a reduction in hard clinical endpoints, so it's less target lesion revascularization, less bifurcation-specific MACE. I think this supports what we've been saying, that if you don't need to put a stent in, you shouldn't because you pay a price with that. We did get a signal that dual stent strategies may be favorable in the setting of extensive large caliber side vessel disease, but this is very much the minority of patients in EBC Main, but perhaps this would explain why the results of DK Crush are the way that they are. That's all.
Thank you very much. So the study is open for discussion.
Congratulations for the excellent, it's an amazing amount of information. The results you have just presented are intention to treat, right?
All on the intention to treat analysis, yes.
Okay.
Yeah.
Then, modestly, I think that there was a problem with the randomization. It's statistically, I mean, the probability that you get that bias in the side branch characteristics in a group of 500 patients is negligible. And especially favoring the two-stent techniques in those lesions at the side branch that most likely profit the most from the techniques. I guess there was a problem in the randomization.
Yeah, I mean, there could have been selection bias into the trial, but once the patients were randomized, I mean, a 2 millimeter approach probably statistically is maybe, not clinically significant. There shouldn't really have been a reason why the randomization failed.
The truth is the fact that even if something is let's say, improbable, it happened. Because, I mean, randomization was performed as usual. I mean, there was a communication and computer-generated system that was unaware about the complexity.
I mean, in EBC2, there was almost twice the rate of bystander PCI in the two-stent group compared to the
sure, I mean,
traditional,
it is important. I mean,
yeah, but it's just a coincidence.
Yes, but what was he was telling that there was a significant difference despite the randomization in the baseline, some in favor, some against, across in favor.
Well, I would not disregard.
It depends from the variable that are listed when you have to randomize, but it happens. I mean, it's not
yes,
this happens, but it's a rare coincidence.
This is a Corlab QCA analysis, and there was no QCA analysis to be submitted at the time of randomization. Okay.
It's operator reported.
But
this is QCA,
okay.
Corlab, and randomization was done without any QCA analysis.
Uh-huh.
Okay. As usual.
Yeah, but do you understand my point? It's
yes,
nobody.
Yes.
Yeah. It's just a very rare coincidence that the group with longest lesions at the side branch gets more to stent techniques. I guess you have already thought about that, and probably you had to answer some reviewers' remarks about that. I guess.
But was that the case? That there were longer lesions in the two-stent group in the overall study?
Yeah, I don't know if we can get the slide
I'm
back
sorry,
up. So the dual
perhaps
stent,
I missed that,
yeah,
perhaps. So.
the mean side branch lesion length in the dual stent group was 7.9 millimeters, and the mean in the provisional was 5.8. So
And was that statistically significant?
That's statistically different,
Okay.
yes, yeah.
Can I just clarify? When you have two groups and there's randomization, if you have enough variables, then some of them will be different between the two groups. And by the play of chance, in this situation, in this particular clinical trial, that difference was met in the lesion length.
I'm sure you're too young, but Geminis did not benefit from thrombolysis and.
I do remember that, but this is all, like I said, it's hypothesis generating, but actually
However,
fits
I mean,
logically with
beyond
what we know.
beyond. I mean, this that is for sure. I mean, a good comment. I mean, that should be explained just with the statistical limits of the sample size. I mean, if you have a 3,000 patient study, it is less probable that you will have this kind of problem. Anyway, I think that what you also not only performed good analysis but also commented well, because when we had the first result of this trial, we thought that we were completely against the decay crash results. And now, I mean, it seems that over time we are understanding better the fact that probably we treated different patients, and probably this is more important for the selection of the technique than the technique by itself, because now, I mean, we have the signal that is in favor of double stenting when you have extensive disease in the side branch, even if in our trial decay crash was marginally applied. This is also important point, because it seems that when you have extensive disease, the double stenting technique can be more effective than provisional, even if decay crash is not the double stenting technique, because it was marginally applied in the trial.
Well, actually, I think this new analysis, taking in consideration the length of lesion also in EBC main trial, answered why that difference between decay crash and EBC. So I think one of the main factors impacting the results is the length of lesion on side branch.
Yes, yeah, very much agree with that. And I think
So
it's
if
also...
you will redesign this study, what you will change in the
Well, I think the
in
study
the
needs to
inclusion
reflect,
criteria?
the study needs to reflect what your clinical practice is. And the truth is that the clinical practice in Europe is that patients with very extensive lengths of disease get surgery, or they might be a case that you do once or twice a year. You can't do a randomized controlled trial. What you need to study is the population that you frequently do PCI on for left main disease, and that is the population that was included here.
Okay.
Well, the alternative is that we do the sickest patients also with bad disease who the surgeons don't want to do. And maybe that's the patient group the study is a big group. But when you say that particular aspect of the longer lesion length patients seeming to benefit from the two-stent technique, that just supports already randomized trial data in a different population, right? So it's hypothesis generating, but it's already supported by randomized trial data from another trial.
If I can comment, I will give you the word. I also can speculate the fact that in the EBC main trial, since decay crash was marginally applied, also double stenting group received the provisional flow to receive two stents intentionally. This also, challenges the fact that the only effective way to implant two stents should be decay crash.
Question about the crush. I didn't understand completely in the EBC main trial when I think there were 10% or whatever that were called crush. Were those decay crush or they were not decay crush? Okay.
I just wanted to add that length in decay crash 5 was 17 and here was 6 and 8. In definition 2 was 20. So we speak about 8 in two stents versus 17. Really difference which is striking. So completely
striking. Yes, what is good and new, I think, today is the fact that this striking difference also, in the subgroup that was similar to the other of our trial, provided similar results. David.
Yeah. To Vlad's point there, only 5% of patients did have a crush, but in the protocol it did say that if a crush was to be done, then DK crush was strongly to be favored.
Provisional stenting is also a double stenting technique.
So yes, I mean,
I have treated multiple bifurcation in my life. And even with very long lesion in the side branch, I always put the stent first in the main vessel.
Okay, but I also know that in the trial there was...
was the problem with DK crush that in the DK crush, the provisional group was considered as a bailout. And they left untreated long segments. Only 44% of the side branch were stented, and that explains the amount of acute MI that we can see in the first week in DK crush 5. Look at
that's a pretty large crossover, 44 or 47%.
But
that's almost half people crossing over.
The same patient were in the two groups.
I think 48.
So if you need, if you have a lesion which is 16 millimeter in length,
and
up to 30
that's
millimeter, I know since the 80s that we cannot be treated that with a balloon. We know that since the 80s.
Yves, and now we have data showing that, really, it makes sense sometimes to plan the implantation of two stents. What is also important to understand is the fact that I remember that there were some double stenting technique performed by inverted provisional. This means that in the case of stenosis disease into the circumflex, some EBC Main operators decided to perform dual stenting using inverted as suggested by the protocol. I think we should go forward. Thank you very much. And I think next presentation is from remote. We have Kefei Dou, left main bifurcation stenting, impact of residual ischemia on cardiovascular mortality. Welcome.
Yeah, hello everybody, but it's not
Hello
a presentation.
everyone, I'm Dr. Dou from Huai Hospital, Beijing, China. I'm very glad to share our latest research entitled Left Main Bifurcation Stenting, Impact of Residual Ischemia on Cardiovascular Mortality. As we know, left main coronary artery disease has long been recognized as a crucial anatomical subset of coronary atherosclerosis. Left main CD frequently involves distal bifurcation, and PCI for left main bifurcation is associated with more complex procedures and inferior outcomes compared with isolated osteo or shaft lesions. Using wire-based physiological assessment, previous study found that nearly 16.9% of patients had residual ischemia in circumflex after left main crossover stenting and associated with poor prognosis. The present study aimed to determine the rate and prognostic implications of post-PCI physiological residual ischemia according to MuQFR after left main bifurcation PCI. MuQFR is a new generation angiography-based computational physiology index, and it has been proven to be more appropriate for analysis of bifurcation lesions with good diagnostic accuracy. The present study is a post-hoc blinded analysis from a prospective cohort which consecutively enrolled patients with unprotected left main CD PCI at Huai Hospital. The primary outcome was 3-year cardiovascular death. Major secondary outcome was 3-year bifurcation-oriented composite endpoint, BOCE, defined by the Bifurcation Arc Consensus document. MuQFR assessments were performed separately in main vessel and side branch based on different single angiographic views. Residual ischemia was defined by post-PCI MuQFR values less than 0.8 in LAD or LCX. As shown in study flow, 1,320 patients with unprotected left main bifurcation stenting were prospectively enrolled. After excluding 150 patients with AMI or unanalyzable mu-QFR, 1,000 or 170 patients were finally included in the present study. Post-residual ischemia was detected in 155 patients, including 117 with LCX ischemia alone, 32 with LAD ischemia alone, and 6 with both LAD and LCX ischemia. Compared with no residual ischemia group, patients with ischemia group had more comorbidities, lower left ventricular ejection fraction, and more extensive CAD. Regarding procedural characteristics, the residual ischemia group was associated with lower number of two-stent technique and a final kissing balloon inflation and higher residual syntax score. After multivariable logistic regression analysis, we found 8 independent predictors of post-PCI residual ischemia, including LVEF, true left main bifurcation, pre-PCI LCX RVD, anatomic syntax score, pre-PCI LCX mu-QFR, treatment strategy, post-PCI LCX diameter stenosis, and residual syntax score. When we look at 3-year clinical outcomes, the rate of cardiovascular death was significantly higher in residual ischemia group, 5.4% versus 1.3%. After adjusting possible confounders, the adjusted hazard ratio was 3.2, and incidence of BOCE were also significantly different between patients with and without residual ischemia, 17.8% and 5.8%. Moreover, residual ischemia, regardless of LAD or LCX, was associated with worse outcomes, especially among patients achieved acceptable physiological results in main branch. Residual ischemia in LCX alone was also associated significantly higher rate of 3-year cardiovascular death, 6.2% versus 1.3%, and BOCE 17.2% versus 5.8%. In addition, clinical outcomes were inversely and continuously associated with post-PCI mu-QFR values, and per 0.1 decrease in post-PCI mu-QFR value. The risk of 3-year cardiovascular death and BOCE increased 27% and 29% respectively. When using post-PCI mu-QFR or diameter stenosis percent to define physiological or anatomical significance respectively, mismatched results were found in 177 patients. Among these patients, physiological assessment showed superior prognostic value for 3-year clinical outcomes. In the present study, we found that after angiographically successful left main bifurcation PCI, residual ischemia assessed by mu-QFR was identified in 13.2% of patients and was associated with higher risk of 3-year cardiovascular death. Toward a more perfect interventional algorithm, adopting the strategy of routine post-PCI physiology-based assessment when treating left main bifurcation lesions is necessary, even when PCI appears anatomically satisfactory. Thank you for your attention.
Is the author connected? No. Okay. Is there any comment about this study from the panel? I don't think she. Sorry. I don't think you are Dr. Dou.
No, she's the next speaker.
Okay, so we will discuss later on. So is there any question on this? No? Any comment?
I guess that there were no data about how many patients could be optimized after finding a suboptimal result. Because sometimes the physiology is not always possible to optimize the result according
Yes,
to the
for sure. I
physiology.
mean, this is the limit. However, I mean, the signal is there. The operator were satisfied with that, and then at the end you find that there is impact for what so the completeness of revascularization in patients undergoing left main PCI seems to be important. There are many ways, actually, if you look at the trial to do this. Physiology was one of that, Synta score residual is another that was stratifying the outcome. Now we have this new tool that is the functional, that can be intermediate between the functional done with pressure wires and the angiography done just by angiography. So it seems a new tool that can be useful. Okay, next. Last but not least for all EBC is Dr. Annette Mazninka. I hope I said it correctly. Patterns of restenosis after single or dual stent implantation for left main bifurcation PCI, a sub-analysis of the EBC main trial. Sorry.
Thank you. So good afternoon and dobry wieczór. I'm very grateful to be here and thank you for the invite to give this last talk of this fantastic meeting in this country that I love and originate from. I'm presenting this work on behalf of the EBC Main trial investigators, and it's a sub-analysis on patterns of restenosis after left main bifurcation dual or single stenting. The only relevant disclosure is that EBC Main was supported by an education grant from Medtronic. Sandeep eloquently presented the EBC Main 3-year results, which showed higher target lesion revascularization with upfront dual stent strategy compared to stepwise provisional approach for left main bifurcation PCI. Prior registries showed higher target lesion revascularization with dual compared to single stenting, driven by circumflex ostium restenosis. Improvements in stents and pharmacotherapy have improved PCI outcomes, but restenosis location and its relation to stent technique after contemporary PCI is not well characterized. The aim of this sub-study was to investigate patterns of restenosis after left main bifurcation PCI in the EBC Main trial, and to investigate any differences between dual and single stenting. To recap, EBC Main was a multi-center randomized trial in 467 patients with stable and unstable coronary disease who had true left main bifurcations with both branches greater than 2.75. Patients were randomized to the stepwise provisional approach or the upfront dual stent strategy with resolute onyx stents. Clinical events at 3 years were adjudicated by an independent clinical events committee. And this sub-study included all patients who underwent target lesion revascularization and had information available on restenosis location. The decisions to do invasive angiography during the follow-up period were made by local clinicians based on ischemic symptoms or non-invasive tests of ischemia. QCA was performed by a core lab, and significant restenosis was defined as lesion diameter stenosis of 50% or more. Restenosis was recorded in the left main, ostial and proximal LAD, and ostial and proximal circumflex. 8 patients who had target lesion revascularization had missing information on restenosis location, so we included 48 patients in this sub-analysis. 13 had single stenting, 35 had dual stenting. In patients that were treated with dual stenting, 89% had been randomized to the upfront dual stenting approach. The mean age was 70 years and 73% were male. The proportion of diabetics and current smokers was similar between the two groups. Most patients had Medina 111 bifurcation disease, and half had at least moderate lesion calcification. The LAD was the main vessel in 2/3 of cases. In patients treated with single stenting, 2/3 had left main to LAD stenting, 1/3 had left main to circumflex stenting. Among patients treated with dual stenting, the technique used was clot in 57%, crush in 37%, T or tap in 6%. LAD stent diameter was similar between the two groups, as was circumflex stent diameter. Nearly all patients had kissing balloon inflations, and half of these were exclusively with non-compliant balloons. POT was performed in nearly all patients. So here we see the pattern of restenosis in all patients who had target lesion revascularization included in this study. 58% had isolated ostial circumflex restenosis, 13% had isolated distal left main restenosis, and 6% had isolated ostial LAD restenosis. We can see that the isolated ostial circumflex restenosis was what most common, regardless of single or dual stenting.
Can you help her?
The mean percentage diameter stenosis at the circumflex ostium was 62%. And this wasn't associated with dual or single stenting, lesion calcification, bifurcation angle, or kissing balloon inflation exclusively with non-compliant balloons. If we look at the patients who were treated with dual stenting, there was no significant difference in the pattern of restenosis between those who had the upfront dual stenting approach compared to those with the stepwise provisional approach. Interestingly, patients who had single stenting from left main to circumflex had worse mean percentage diameter stenosis for lesions at the LAD ostium compared to patients who had left main to LAD stenting. But in contrast, the mean percentage diameter stenosis at the circumflex ostium for lesions there was high, irrespective of left main to LAD or left main to circumflex single stenting. So the take-home message is that stent coverage of the circumflex ostium does not protect from restenosis. So what's unique about the circumflex ostium? It often has steep angulation, which is associated with a hinge-like motion during the cardiac cycle, potentially predisposing to stent fracture. Changes to the circumflex ostium with stenting include vessel straightening and change in local shear stress, and that can potentially lead to vessel wall damage and potentially increase the risk of neointimal hyperplasia at that point. It's also a common site for stent underexpansion because proximity to the aortic wall predisposes to rigidity and recoil due to higher fibroelastic fibers. So compared with stenting, a drug-coated balloon to the circumflex ostium might have advantage, and this is because it combines mechanical expansion of the vessel whilst limiting inflammatory stimulation, but without implanting a permanent scaffold. So it preserves the geometry that was originally there for the coronary anatomy. A relevant ongoing randomized trial is DCB-BIF, and that's randomizing patients with true bifurcations to stepwise provisional strategy with drug-coated balloon to the side branch or non-compliant balloon to the side branch. So in summary, the strengths of this sub-analysis are core lab analysis, independent adjudication of clinical events, and high follow-up rates. The limitations are that it's a post-hoc analysis for randomized trial. There was missing information on restenosis location in 14% of patients who underwent target lesion revascularization, and routine angiographic follow-up was not performed. In conclusion, 3 years after left main bifurcation PCI, the circumflex ostium is the commonest site for restenosis requiring revascularization, and this remains true irrespective of dual or single stenting. strategies are needed to improve longer-term PCI success at the circumflex ostium. I'll finish by thanking Prof. Dayfield-Smith for his support and mentorship. Thank you very much for listening.
Very good study. Have you any information on intravascular imaging in these patients?
Yes, so as was reported, about 40% had intravascular imaging, so it was about similar in this
Because
subset.
I think it's very important data, because particularly in two stents technique and the ostium of left main could be missed by the stent.
Yeah, so interestingly, I did publish the intracoronary imaging outcomes for EBC Main. And because the trial wasn't designed to focus on intravascular imaging, it was done according to operator preference. And it wasn't protocoled to recall all the detailed parameters that we get now from intracoronary imaging studies. So there potentially was bias in perhaps using intracoronary imaging more in patient procedures that weren't progressing that well. So that's why I've chosen not to focus on that particularly in this presentation.
Have you any information about the treatment of these restenosis, especially after provisional stenting?
So I didn't, well, these were patients who did get revascularization for these target lesions, but I didn't actually look at the strategies that were used. We probably have that information, but I didn't include that here.
In the meantime, I imagine you are going to publish this data. It can be advisable probably to simplify the reporting with all the kind of restenosis to quote restenosis types using Medina again. It can be, something that make the paper more readable for people, because you have this reporting of the various combinations, so that we will know that the most common type is a Medina 001 of restenosis. It will be.
Yes, okay.
So I have a question. Did you actually see stent fractures on repeat angiography? Did you actually see those? And then I have a comment also.
Yeah, so I can't really comment on that. I didn't really have that information, and I guess it might be easier to see on intracoronary imaging. I'm not sure how many use that.
So one thing I've learned over time, if you do imaging at the ostium circ, there's always eccentric calcium or ring of calcium. And in my practice, what I've done is really use shockwave there as a lesion prep before I do anything else, like add another stent or consider drug-coated balloon. So you may be, in part of this trial, you may want to do better lesion prep using shockwave, the ostium circ, which might give you a better result.
I can tell you that your comment is very smart, because we're talking about which is the true impact of imaging, and we have different protocols. And in the October, there was an intermediate scan that was performed, OCT assessment, after main vessel stenting. That also allow to see what's going on into the side branch, because from OCT you may see the very. So what you are arising is the fact that during these procedures, probably it can be advisable to check for the expansion, for the bulking or appropriate expansion of the side branch, the circumflex, before implanting the stent if you are needed.
Only a comment that this finding is not new. So I remember the era of the bare metal stent, and when we analyzed the follow-up, the most frequent site of restenosis was always the side branch origin, disregarding left main, LAD, circumflex, or right coronary artery.
But since we worked so hardly to improve, it is really important to see that some problems are still there. So we should really.
It's a mystery.
Go on.
But it's a fact.
Just a point. Normally in trials, you stop the follow-up at the first event. Yeah, you are not looking at the treatment of this first event. I mean TLR. And we are not looking at what occurred during the second treatment, after maybe a third treatment. Remember last year we had a case of three stent in the left main coming from Indonesia, and our colleagues showed the first stenosis, the second one, the third one, the fourth one. So I think it will be interesting to collect the event even after the first one.
Agree.
I think will be an interesting point.
It is. I think that also in drugs trial, this is something that was discussed because most of Kaplan-Meier and statistical report are, like you say, stopped at the first event, but there is a hierarchy in events and number events that can jeopardize the quality of life of the people. So very smart. Okay. I think that the music is thank you very much, and music is introducing Goran for his final remarks.
One brief sentence, and this is the end of 19 EBC club meeting. So we started in 2005, and in these 19 years we really became a family. Having members from all over the world. We are European Bifurcation Club, but at this meeting we had lectures from all 5 continents, and I'm really happy that we promote inclusiveness and diversity. And the only difference is that now we have many more young faces in the audience, and I'm really glad to see more women and more young people to replace us. EBC is working on a transition. Last year we decided to make 2-year term for the executive board. So this is our first year, and we will do one more. And at next EBC meeting at 20th, we will have new executive board. So I'm looking for your support, and I like to invite you to continue sending good ideas. I believe we should remain think tank. But as you may know, we shared the Zoom link with absolutely everybody on Twitter, on mails. So everybody can listen to our discussions, but this is really place for a couple of 100 maximum people who can actively produce the consensus, discuss the evidence, exchange experience and practice, and help us build the consensus that we will share. So I would like to thank the industry, of course, for the kind support to make this possible. Big thank you to all of you for being with us 2 days from the morning until now. And at the end, although Alexandra is not here, big thank you to Mediate Events, Alexandra and her team, because this was really beautifully organized. And I'm so happy that Alexandra found such a beautiful place, and we look forward to the next meeting. So pick up for dinner is at 8 o'clock in the lobby, and I look forward to seeing you all. Thank you very much again.